بسم الله الرحمن الرحيم. طبعا عمال استعجل الناس كلها فاولى ان انا استعجل نفسي. So I'll try to be as short as possible. وسعيد جدا بالتواجد يعني من الصبح لحد دلوقتي. انا عارف وجبه دسمه من الساينتفك اكتيفيتيز لكن هكذا تكون الامور. So my talk today is about apixapan and stroke prevention and atrial fibrillation, evidence and clinical experience. This is actually a sponsored presentation, and I'd like to thank Pfizer for their CME continuous activity and support. Of course, as being co-chair of this conference, I'd like to thank all companies, of course, for being with us. So let's start with the slogan: treat often, cure sometimes, comfort always, and harm nothing. So this is the background. So this is the estimated prevalence of atrial fibrillation and the incidence related strokes worldwide and in Egypt. This is, we have very significant burden of atrial fibrillation. Egypt ده الداتا دي اظن كانت 2015 2014 كانت اعداد مصر 90 مليون. Now they are more than 100 millions when prevalence of AF is 1%. So there's significant mortality and morbidity burden associated with AF. AF is associated with mortality, death. Death due to pump failure, death due to hemorrhagic stroke, death due to thrombotic stroke. So there are many causes of mortality in patients with atrial fibrillation. Disregarding mortality. What about morbidity? There are so many morbidities with atrial fibrillation. Heart failure is one of the important comorbidities with atrial fibrillation. Exercise intolerance, strokes, either hemorrhagic strokes or thromboembolic strokes. So it's important that we have to give patients with atrial fibrillation a preventive measures to guard against occurrence of thrombotic strokes. One of them is vitamin K antagonists, which are highly effective for stroke prevention AF. So if they are effective, what's the point here? The point here, missed doses, number one, labile INR. الINR النهارده ممكن تعمله العيان يطلع 2.5، you are happy somehow. بكره او بعد اسبوعين تعمله تلاقيه 5 والعيان ابتدى يحصل بليدنج. بعدها ب3 أسابيع لما نقلل الدوز شويه تلاقي الINR بقى 1 او اقل من 1. So شويه فوق وشويه تحت، الريسك اوف شويه الريسك اوف بليدنج يعلى وشويه الريسك اوف ثرومبوزيس يعلى، وبالتالي this is why they're searched for other than PKA antagonists for management of thrombosis. There are many causes for this labile INR. Patient-related, drug-related, morbidities-related, so there are many causes for that. And there are many targets to control which make it more important to search for new era of direct oral anticoagulants, as I explained before. So all this provided a strong rationale for development of NOACs. So this is the mechanisms of NOACs, and some of them is working directly by inhibiting activating factor 10. صوت بس بعد اذن حضراتكم just for me and for your colleagues of course. So definition of non-valvular AF. Non-valvular AF is presence of AF in absence of mechanical prosthetic heart valves and in absence of moderate to severe MS. أي عيان عنده atrial fibrillation ومش مركب mechanical valve وما عندوش severe أو moderate to severe mitral stenosis, this is non-valvular AF. بيشكلوا كام في المية تقريبا؟ almost 80 to 85% worldwide. So you have too many categories of patients who can benefit from direct or novel oral anticoagulants. There are many trials for oral anticoagulant trials with intracranial hemorrhage as one of the endpoints, including dabigatran, rivaroxaban, apixapan, edoxaban, and many other direct oral anticoagulants. أنا بقول الصوت هنا يطلع هنا ينفع كده. So Meta-analysis showed significant relative risk reduction in stroke and strong trend towards less bleeding with full dose of NOACs versus warfarin in non-valvular AF. ايه اهميه ان احنا نكتب النوفل اورال او الدايركت اورال انتي كواجولانتس فور بيشنت rather than ان احنا او ان هم ياخدوا وارفرين او الفيتامين كي انتاجونست، ان انا عندي less labile INR وبالتالي less prevalence and incidence of either hemorrhage or thrombotic strokes. That's very important. كون ان العيان كل شويه ينزل يعمل التحليل والعيان is a patient وفي حاجه اسمها الكير جيفر، ده وقت. What equals time is money. في مصر وغير مصر time is money. So meta-analysis prove significant reduction, relative risk reduction in stroke and strong trend towards less bleeding with use of NOACs. This is the ECC guidelines of NOACs recommendation in preference for VKA for patients who are eligible for NOACs. هنجد ان اي عيان عنده AF proved ان هو ما عندوش mechanical valve وما عندوش severe moderate to severe MS، ودلوقتي في running trials على فكره either في mechanical valves وايضا في moderate to severe MS prior to use them. However, this is not in the guidelines عشان ما اعملش تشويش بس في knowledge. What's in the guidelines that you can use it in non-valvular AF. So reasons for using specific novel anticoagulants: greater efficacy, lower all-cause mortality, no increase in GI bleeding, efficacy and safety. هو ده البالانس بتاع اي دواء، اللي يبقى safe and effective. Sometimes السيفتي تيجي على حساب الافيكاسي، sometimes الافيكاسي تيجي على حساب السيفتي. If you can balance both, perfect. This is the perfect recipe for effective drugs. So, safety of apixapan in stroke prevention atrial fibrillation. So there are many trials exploring how apixapan versus warfarin is effective in prevention of stroke in those patients without added risk of bleeding, which is very important, or mortality. So, efficacy and safety, as I said before, there are many trials like Aristotle, apixapan 5 milligram twice daily was actually less stroke and systemic embolization and without significant major bleeding on those patients. So that's important. ان هو يكون effective وبالتالي هيبقى فيه يعني prevention of thromboembolism and systemic embolization وفي نفس الوقت safe ان ما يحصلش معاه major bleedings every now and then. What about mortality? Again, mortality is less head-to-head studies don't exist طبعا, so direct comparison is out of here. However, we can say that mortality, there is a trend for better mortality outcome with apixapan as well. What about gastrointestinal bleeding? Sometimes we see many patients having some sort of anemia when they are taking oral anticoagulants. You do hemoglobin or CBC, hemoglobin is 5 or 7. الناس الكبار في السن بالذات يعني بالراحه فجاه تلاقي الهيموجلوبين 5 و7 ودي is a big problem actually. However, only apixapan didn't significantly alter the risk of major GI bleeding in comparison to warfarin. Overall trial results, there is Averosis and Aristotle trials where both of them طبعا مش هقدر حضراتكم بداتا كتيره about the structure or methodology. However, both of them were effective in stroke prevention, systemic embolization reduction without no added cost as regarding bleeding, where mortality are nearly there, trying to save some time. Apixapan has demonstrated superiority versus warfarin in all of the following 3 outcomes. ودول main important outcomes that anyone should search for if they are searching for safety and efficacy in stroke prevention in patients with atrial fibrillation. Superior stroke systemic embolization prevention with significant relative risk reduction, superior profile in less major bleeding, and superior reduction in all-cause mortality. If you can get all those 3, so you are successful, hopefully. Discontinuation rates with, of course, with apixapan is less than other novel oral anticoagulants, and of course less than with warfarin, which is very important actually. Sorry. And once a daily versus twice daily. Of course, if you can give the patient twice daily. sometimes ممكن البيشنت ذات نفسه يشوف ان دي حاجه يعني الصم يعني for him is not compliant for that. However, sometimes patients on one daily dose they might have some fluctuations. طبعا not all drugs have this. However, some drugs might have some fluctuations because they don't work around the clock of 24 hours. So being twice daily is not a big deal. This is how you give patients doses of apixapan. If is a geriatric patient above 80 or low body weight or high serum creatinine, so you can give 2.5 twice daily. Severe renal impairment, 2.5 twice daily, but the standard dose is 5 milligram twice daily if there is no contraindication. Reasons to use apixapan in non-valvular AF: greater efficacy and safety, lower all-cause mortality, efficacy and safety, no increase in GI bleeding, and lower discontinuation rate. This is the antidote for apixapan. 3 years ago when I prepared this presentation, something like this, there was no antidote for those drugs. It's very expensive anyway, not available in all places anyway, but it's there. An antidote for apixapan, which is andexanate alpha. And this is apixapan versus warfarin in patients with atrial fibrillation. So even in patients with atrial fibrillation post acute coronary syndromes or post PCI, ودي هتبقى specific topic for my elegant colleague Professor Tamer Mustafa from Zagazig University. Now, antithrombotic therapy after acute coronary syndromes, apixapan is one of the preferred drugs for using of non-valvular AF, prevention of stroke, prevention of systemic embolization in patients with atrial fibrillation. This is my take-home message. Apixapan is indicated in non-valvular AF, 5 milligram twice daily, orally. However, in patients above 80 and above, in patients with low body weight less than 60 kilograms, in patients with high level moderate elevation of creatinine, you can give 2.5 twice daily. For venous thromboembolism, 10 milligram twice daily for 7 days, then 5 milligram, which is the standard dose. For prevention of recurrent VTE after 6 months, 2.5 twice daily. For prophylaxis, 2.5 twice daily. There are some drug interactions which you should have. يعني مهم جدا في بعض البي ان اف ده وده موجود free online. You can see the drug interactions are nearly there. No X are superior to warfarin in reducing stroke, embolization, hemorrhagic stroke, and all-cause mortality. Apixapan is one of them. Demonstrated superiority in stroke, systemic embolization, major bleeding, and all-cause mortality. It didn't show significant increase in GI bleeding. Apixapan is safe in NF in post-PCI, and in comparison to aspirin or warfarin, it was effective in reduction of these points. Thank you very much. I did it.